First of all, I'd like to thank the organizers for giving me this opportunity. It was very nice to see many friends on the platform, and it was very good to see Professor Greenwald for his nice words, and thank you, chairpersons, for your patient waiting as well as your good comments on this. Next slide, please. Is slide not moving? Ah, yes. See, in my talk, I just would like, it is actually a dream for every endoscopist. When you do an endoscopy, if you see a lesion, to know what's the pathology of that. So this is it possible or not? We know that there are many techniques by which you can actually enhance the quality of the image and try to find out a diagnosis. In my talk, I'll be just briefly touching upon on image enhancing endoscopy, as well as on optical in vivo histology modalities. And I'll be concentrating more on endocytoscopy and artificial intelligence endocytoscopy. Next slide, please. See, next slide. In early detection of GI cancer. Next, you have magnifying endoscopy. Next, chromoendoscopy and optical chromoendoscopy. That is narrowband imaging. Next, but we know that next we have two other modalities which actually look at the histology as well. They are confocal endomicroscopy and endocytoscopy. Next slide, please. See, on chromoendoscopy, you can see that the Japanese have already learned this art much earlier, and they can actually identify the extent of the lesion, and it also helps to identify or to know about the nature of the lesion. But this cannot give an optical histology. Next slide, please. But because of this magnifying endoscopy combined with optical chromoendoscopy, that is NBI, people have tried to diagnose with the vascular and the pit patterns whether this is malignant or non-malignant. And you know that this is a JNET classification of different types of polyp to come to a conclusion. Next slide, please. So in magnifying endoscopy, you assume the diagnosis by cellular changes from the mucosal pit and vascular pattern. You say this is malignant by looking at the pit pattern as well as by the vascular pattern. But in optical histology, it is you observe the shape and change of the nucleus as well as a cell for optical histology. Next slide, please. This is actually when doing a colonoscopy, I found a leaf on the colon. Next slide, please. This is a white light endoscopy. This is actually a image enhancing endoscopy. Next slide, as a magnifying endoscopy. Next slide. And this is a narrow band because of the dead leaf and because of the bile there, you get a red color there. Next slide. Next. So when you do a zoom endoscopy, like endocytoscopy, you can see the cells, and here there are no nucleus because this is a dead leaf, and you can see a very clear-cut picture of the cell wall and structure. Next slide. Yes, we can see that now it is very clearly seen that the cellular structures are variable. This is actually the optical histology or optical biopsy. Next slide. So from white light, we have gone up to a cytological analysis by endoscopy. Next, please. Next. So optical histology or supermagnetic. Next, you have got two aspects, as I told you, two modalities like confocal laser endomicroscopy and endocytoscopy. Next. Next slide, please. Optical histology is basically you apply the endoscope to the target mucosa during endoscopy examination and diagnose the cells on that, living cells. That means in vivo, you try to make a diagnosis, whether it is normal or abnormal. And you capture the ultra magnified pathology images and try to differentiate between neoplastic and non-neoplastic lesions. Next slide. When you take confocal laser endomicroscopy, it's one of the modalities which actually was being used many times and now still is used in certain centers. And it illuminates tissue with a low power laser. And it detects fluorescent light reflected from the tissue through a pinhole. The image is reconstructed and it has got an increased spatial resolution when compared to endocytoscopy. But as I told you earlier, it relies upon the tissue fluorescence. So you require either an intravenous fluorescent injection or topical application. Next slide. So you have got a probe-based or scope-based, and scope is not being commonly used now, and it is probe-based. Next. You can see the cross-sectional as well as the longitudinal, very good images on that, but it's black and white. The beauty of it is that it can go up to 1,000-fold magnification. Next slide. And you can actually, there are different classifications. The most popular is the Miami classification for the confocal laser endomoscopy, especially for colonic lesions. And you have enough changes on this laser endomicroscopy by which you can say probably this is malignant, it's non-malignant, this is neoplastic and non-neoplastic. And even you can identify inflammation. Next slide. But in endocytoscopy, it's actually a scope which has got a microscopic eye, and then it actually give you a pathological diagnosis under an endoscope. So the image enhancement go up to 520 or more than 500 times. Next slide. Just next slide. This is actually endocytoscopy. This is an old generation video. You can see the squamous cell epithelium normal. Next. Just press it again. And now it is crowded nucleus seen there in the esophagus. That is suggestive of malignancy. That is actually an old one, and it's actually Curated by Olympus. Next slide. So there are different types of generations of endocytoscope as evolved, and now we have got the fourth generation that was actually introduced in 2015, and it has got integrated single endoscope with a continuous zoom and magnification more than 500 times. Next slide. This is just a video cartoon which actually shows that you have to come in contact with the endoscope, and there is a zoom lever, and you have to adjust the lever, and you then get a magnification, partial magnification. You see some structures of that and vascular pattern. And when you come in contact, then you get the maximum magnification, and you can see the lever, zoom lever is pushed to the maximum. You get a 520 or more than 500. Then you can see the cells there, as well as you can see the pattern of mucosa inside there after staining. Even without staining, with narrowband, you can look at the vascular pattern, and both, and you can see in the upper GI as well, the esophagus as well as the colon. Next. The basic principle of it is that, when you come in contact with, there's a light guide which actually produces scattered light, and then is taken up by other lens, and those who have been stained, it will be easily picked up. So you get a superficial layer imaging of the mucosa. Next slide. Again, this actually shows that the liver is there, and then you can actually stain, and then you get an image very good for that interpretation. Next slide. So what you need is you need a 290 system for this. Fortunately, it is available in India since last 1 year, and I am fortunate to get one of that 1 year back. Next slide. Next. So there is a procedure for doing this, and I'm not going to details of it. Next. The most important thing is, you have to wash that area, clean it, and find out, do a good white light endoscopy, then do a narrowband imaging, and then you come back and then actually look at that, wash the area very clearly, no mucus, then stain it, and then you adjust your scope also. You have to actually, next, you can actually see that you have to change the red and blue tone adjustment need to be done. Next. You have to keep it in -8. You get that shown there. You have to keep it -8 and +8. Next. Then you do the study. Actually, and the contrast used is, the stain used is actually crystal violet and methylene blue. You make a combination of that. You take 10 cc of 0.05 crystal violet and 1 cc of methylene blue and mixed. And you take 1 ml in each syringe and 9 ml of air in that and push through the channel or through the accessory equipment like spray catheter. And then you put drop by drop and see whether it's at the area where of interest is stained or not. Next slide. So here actually, why you require 2 stains? Methylene blue is one stain which actually stained the nucleus, and then crystal violet is another one which stained the nucleus and the cytoplasm, but in the same color. So if you use a combination of these two, next slide, you get a CM staining, that is crystal violet and methylene blue staining. Next slide. And that you get an adequate staining, a proper staining. Next. So coming to the colon, it is thought that endocytoscopy can actually identify the lesions, and then you can classify into different types of them. And the classification is EC1, endocytoscopy 1A and 1B. They are actually non-neoplastic. 1A is normal mucosa, 1B is hyperplastic polyp. Then EC2 is actually neoplasia, either an adenoma, ranging from adenoma, then to dysplasia, and finally to invasive cancer. So from EC1A to EC3B. Next. And this is actually a hyperplastic polyp. You can see that is actually the probe-based endocytoscopy. That is an older one. And you can see this is actually EC1B. This is a hyperplastic polyp. Next. This is an adenomatous polyp, and it's actually a low-grade adenoma, EC2. Next. And this is actually, you can see a clumping of nuclear material there, and this is actually probably an invasive cancer. You can see the histopathology there and the clumping of nuclear material. This is EC3B. Next slide, please. Just press on. This is actually one of my patients, just to show you the colonic. Just press it, click it, or press for next slide. It's a video. You can see that actually the blood vessels around the crypts, and you can even see the RBCs going through that. Next slide. And here is actually without any staining, you can see even this one, you can see the crypt lumen, and also you can see the blood vessels there. Next slide. Coming to the vascular classification, now you can also use endocytoscopy not only for the nuclear pattern but also for the vascular pattern. We can classify them into three: ECV1, that is non-neoplasia, which I have already shown you; ECV2, that is a neoplasia, and that can be adenomas, and ECV3, that is usually it's an invasive cancer. Next slide. And when you see invasive cancer, next, you can see irregular type of vessels. Next slide, please. Here is actually the normal one, or a hyperplastic polyp, non-neoplastic. There is hardly any vessels you can see. You can see there is any hardly vessels. That's a diagrammatic representation of what you see here. Next slide. And this is actually a ECV2, that is of adenoma. You can see a lot of vessels there, and it is regular, and the crypts are regular. So you saw it's adenoma rather than a malignant neoplasm. Next. And here actually the dilated thick vessels and the caliber has changed and irregular distribution. And that is why we say this is probably cancer and probably invasive cancer. Next. I'm sorry, because of this movement from there, there is some delay. That is the reason. So suppose visibility is not good. You can actually enhance it by actually injecting saline or indigo carbon beneath that. And this is one of the slides which actually shows that. You can actually enhance the pattern of the histology by actually injecting saline underneath. Next. What is the evidence of this in qualitative diagnosis of endoscopy in colonic cancers, colonic lesions? It is found that the diagnostic accuracy is quite good in these multiple studies, and most of the studies are from Japan, and because that is actually introduced in Japan early enough. Next slide. This is one of my patients. Actually, you can see it's probably a type 2B, and you can see a central depression there, and we diagnose it as a flat adenoma, probably type 2B. And next slide. So narrowband imaging, and this is actually endocytoscopy. You can see the tubule is probably a tubulovillous adenoma, and you can see the histopathology is actually showing tubulovillous adenoma, which some increase in number of some atypia there in the cells, probably early dysplasia. Next. But in some areas, we found there is a small area where there is significant dysplasia. So here actually you can see the picture, probably suggesting that is not just adenoma, it is something more than that. Next slide. When coming to the esophagus, again we are using endocytoscopy classification to classify lesions. And we have EC1, that is non-neoplastic. It can be either normal or it can be esophagitis. And EC2 is actually intraepithelial neoplasia. And then we have got EC3, that is actually neoplasia. Next slide. This is just a picture showing that this is a normal mucosa. You can see that regular shaped cells and a small nucleus, a large cytoplasm. And this is probably, there are some cells become more oval or rounded, and this is probably because of some esophagitis, which you see in patients with reflux esophagitis or esophagitis of some other cause. And when they have got evidence of early neoplasm or intraepithelial neoplasm, you can see that number of nuclear material is increasing. And when you have got squamous cell carcinoma, then you can see the pattern changed, and you see a bigger nucleus and lot of nuclear material on endocytoscopy after staining. Next slide. This is one of my patients with actually having a lower esophagus. You can see a case of Barrett's esophagus, and narrowband imaging actually shows there is an evidence of probable dysplasia or neoplasm. And this is the endocytoscopy picture. This actually shows that there is highly dysplastic glands and there is evidence of malignancy. Biopsy, next slide. And again, this actually shows areas, and this is actually showing glands with severe dysplasia, and there is glands with active neoplasm is there. Next slide. Coming to stomach, next slide. Stomach, actually you can see the mucosa and say that probably this is the fundus mucosa, and by looking at the endocytos picture, and also in the pylorus or the antrum, the character, mucosal character change. When there is evidence of intestinal metaplasia, if you look carefully, you can actually look for goblet cells. You can see here there is plenty of goblet cells, and here also you can see goblet cells are there. Next slide. The classification in the stomach is similar, that you do a EC classification. EC1 is non-neoplastic, and EC2 is probably a neoplasm but not malignant. EC3 is cancer. Next. Very important thing is that no non-neoplastic looks like this, and when there is some evidence of neoplasm, either need not be malignant. There also you can see some thickening of the folds, but you can see a little bit increased nuclear material there. But when you see a cancer, you see the difference there, a lot of nuclear material, and there is actually something called, next slide, a big nuclear ratio, something like that. And here actually this is showing three different types of cancers. One is a well-differentiated adenocarcinoma. This is a histology, and this is actually the endocyto picture. And this is poorly differentiated adenocarcinoma. This is the histology, as well as this is the endocyto picture. And signet ring cell, some people say that it can actually try to identify with endocytoscopy. Next slide. This is said to be a very good sign to identify whether it is a malignant or not. That is enlarged nuclear sign. This is very classically said to be a pathognomonic of carcinoma stomach in patients with on endocytoscopy. Next slide, please. This is an early gastric cancer, actually reported by a Japanese group, and you can see a white light there. This is a small tumor. On chromoendoscopy, you can see it's well defined. And then on endocytoscopy, you can see this is the normal looking area, and this is the abnormal looking area, which is showing with the yellow arrows. Next slide. So in any other emerging areas where we can actually utilize endocytoscopy? Probably IBD is one of that area where actually there are some studies saying that confocal laser endomicroscopy and endocytoscopy can in fact look at the inflammatory activity of patients in colon with IBD, and they found that probably you can make a virtual assessment of inflammatory activity. And how it is going to be relevant? Probably, when you do a endoscopy, colonoscopy surveillance, colonoscopy for patients with follow-up of ulcerative colitis, if you can find out that there is actually, if the correlation of this is very good, you can say that probably the patient is in remission, histological remission or something like that. So, but no, up till now, we have do not have enough data to predict that. So probably you need more data on endocytoscopy in IBD. Next slide. This is one of my patients with a malignant polyp in ulcerative colitis, and this is actually pedunculated polyp. You can see on white light, this is an abnormal looking area. This is a polyp, and this is actually probably a cancer there. And endocytoscopy also shows probably a cancer there. Next slide. Narrowband imaging also shows that there's a probably cancer. This is actually which shows different types, pattern of vessels there, dilated vessels, and here actually significantly abnormal vessels, suggesting probably there is invasive cancer. Next slide. And this is the endocytoscopy picture, and the endobrain actually shows it's 99% neoplastic. You can see thickened crypts with a lot of nuclear material. Next slide. Here actually, again, you see this is actually the area of invasive cancer. You can see there is an invasive cancer. Again, this also shows cancer in that polyp. Next slide. This that actually shows tubulovillous adenoma with areas of malignancy. Here also seen. Here also it shows the tumor inside in the villi. Next slide. In the crypts. And the patient, same patient, a rectal biopsy. This is actually ulcerative colitis. You can see a crypt abscess, and this is a cryptitis. And we saw pictures like this. This is a crypt. Whether this is a crypt abscess, I don't know. But this is again a crypt. And you can see there is a lot of dead material inside. And this is a crypt with a lot of inflammation. So this is a cryptitis on that. Probably. This is a probability. Next slide. And this is at another patient. Again, you can see that this is actually the crypt with a thickened lot of cells on that. Again, crypt with thick wall, suggesting of cryptitis. And this is the histopathology of the same patient showing cryptitis. Next slide. What about in H. pylori, Helicobacter pylori? Till now, we have no evidence that you can see H. pylori on in vivo. But now people try to look at on culture medium and try to find out. And they could find out in culture medium, but they in vivo it was not found. But probably it is said that histological changes in the mucosa may be used to make an indirect evidence for this. Next slide. What about in celiac disease? We know that even a magnification endoscopy can sometimes suggest the possible diagnosis of celiac disease. Endocytoscopy is evolving, but probably this is good enough to tell that this patient has got villus atrophy or total absence of villi and many other things on endocytoscopy. Next slide. So coming to my last aspect, that is once you have got a optical histology, if there is an added artificial intelligence, then it becomes easy for you to give a diagnosis. So the combination of these two on endocytoscopy and artificial intelligence. Next slide. You know that computer-aided diagnosis is actually a very most investigated area in the field of endoscopy. It is being tried in colonoscopy as well as in other areas, especially for colon detection as well as for prediction of the histology on that. Because basically colon is inherently an imperfect procedure. You know, sometimes you are likely to miss polyps, and it is found that computer-aided diagnosis can improve its quality. Next slide. And if you have got either artificial intelligence in colonoscopy is used for polyp detection as well as characterization. So if you have got both in one, then it will be very nice. Next slide. Just click on that or just press next. This is actually the endobrain of Olympus. That is actually the computer-aided diagnosis. What you see is you can actually see a area there, and it is showing non-neoplastic because there is no evidence of neoplasm on that. Another area, again non-neoplastic, but here it shows that it is neoplastic because the accuracy is reasonably good. Next, so you have got an endocyto with endobrain to give a computer-aided diagnosis on that. This is actually a video which is shared by Olympus company. You can see that this is a polyp which has been stained, and it shows invasive cancer there. Next slide. The probability, at least you can say that the probability is there. So actually a computer-aided diagnosis will help you a lot. Next slide, please. So a computer-aided diagnosis is, especially in endocytoscopy, is actually based on nuclear features. And CAD system based on endocytoscopy is combined with NBI for vascular features, and that also can say probably there is evidence of malignancy or not. That is using the endovascular pattern, endocytoscopic vascular pattern. Next slide. What are the clinical implications of endobrain or computer-aided diagnosis in clinical practice? Is actually it adopts a visual inspection to optically predict the polyp's pathology as a substitute of histopathological evaluation. And also it's found that preservation and incorporation of valuable endoscopic innovations for optical biopsy, especially in diminutive polyps, where we are likely to leave it. Another thing is, if you see a polyp, you can diagnose and leave if you think it is not important. Or you can resect and discard. Don't send for histopathology for reducing cost of the patient. For example, hyperplastic polyps. But it actually needs a lot of more data worldwide or practice that. Next slide. So ladies and gentlemen, my take-home message for this new technology of optical in vivo histology is that histology is possible through endoscopy, but you need a tissue staining and also you need a high magnification endoscopy, that is endocytoscopy, to do a diagnosis or get a diagnosis. And it is likely that endocytoscopy can revolutionize the field of in vivo endoscopy GI cancer diagnosis. Endocytoscopy could take us closer to the optical biopsy. You can have a faster treatment decision. As I told you, resect and discard also is possible. And artificial intelligence like CAD can definitely open the door to the next generation endoscopy. And endocytoscopy will probably have a more definite role when ESD becomes more widespread. Next slide. Thank you so much for your patience here. I'm extremely sorry for the confusions created.
Thank you, Mathew, for a very comprehensive evaluation and projection of endocytoscopy and endocytology. Now, there are 2-3 questions. What is the cost of your equipment?
See, when you want to do these things, you don't worry about the cost of it.
No. I just want to know.
I don't know. We actually bought everything together, but it's pretty expensive. I'm sure Nagi is sitting there. Nagi will be able to tell that. It is pretty expensive, but it depends upon the interest of the team or the hospital whether to procure this or not. Okay,
let's forget about the cost. What is the time taken to do a procedure on, say, a colonoscopy in a guy who's had, say, screening for polyposis or screening for cancer? Now, by the time you go through all this, it'll take you about an hour. Is that right?
I will not say that because, to the beginning, yes, of course, it takes a lot of time because the 290 system scope has got different light system. So it actually takes a little time for orientation of that. And also the assistant support for spraying the dye and looking at that and washing and cleaning the mucus. It takes some time.
The chromoendoscopy, sorry.
But once you get used to it, where actually this is not used as a screening scopy, though Japanese says that you can actually one go itself, you can do an endoscopy, upper GI endoscopy with endocytoscopy and you can identify lesions and do that. But generally this is actually you do a colonoscopy, you identify a lesion, and if you think that lesion requires further characterization, then you do an endocytoscopy. That is how I do it.
Yeah, fine. I agree because you seem to be one of the guys after Nagi who does this. So the other aspect of this is the total cost to the patient.
This is not very expensive. At least in my center, we don't charge much. And I don't know the different centers how it goes. But this need not be very expensive, I'm telling you. They need not charge too much on that. Because if the number of cases increases, it is not...
No, you're putting too many...
What I have done is, we actually procured a 290 system with an upper GI endoscope, colonoscope, and endocytoscopy upper GI and a lower GI. So I can actually, in one room, I can use this 290 system for our conventional upper GI and lower GI endoscopy also. Then it becomes cost effective for me.
And if you start using your artificial intelligence, I suspect you have it?
Yes, I have it. Yes, I have it.
Okay. I find my friend Tyagi online. Tyagi, you want to say something? Manu.
You want us to stop?
No. I just want to say that we are very defensive about talking of the cost-benefit effects. It's something that has to be inbuilt into a society if we want to take these procedures to volumes. Because I think institutions which are government funded or run on passion can afford it. But can we afford to bring it to the masses by not talking about the cost-effective benefits? And I think that's what ATM was asking.
No, I guess first let's get the technology. I can see Manu smiling. So Manu must have quite a
Yeah.
few under his belt.
No, we had the Japanese demonstrate it to us, and from an institute such as ours, this is not being immodest. I think this is going to be adopted, Mohan. So, but I and Tyagi, when we summarize, we are going to take up this topic when we discuss, which is shortly following Matthew's talk.
Because as I see, there are three aspects. One is the cost involved in acquiring, the skill involved. The skill may not be great because I think everything is given to you. And the third thing is the time involved in doing a procedure.
Thank you.
Thanks,
Thank you
Mike.
so much.
Nice talk.